All right, let's finish up the male reproductive disorders. We're going to finish up by looking at some tumors. We'll discuss benign prostatic hypertrophy, prostate cancer, and testicular cancer. So BPH, pretty common. You'll hear it abbreviated as BPH, but it's important to know it's benign prostatic hypertrophy. Now, this has a high occurrence in men over the age of 65. The half occurs in 50% of men greater than 65 years old. And although it says benign prostatic hypertrophy, there's a hyperplasia of the prostatic tissue. And that creates these nodules, and those nodules end up enlarging the prostate gland. So they refer to it as benign prostatic hypertrophy. And these nodules will compress the urethra and create this urinary obstruction. And when it does, it gives the male the feeling that he has to go and urinate, but just can't. The BPH can be related to imbalances between estrogen and testosterone. BPH does not predispose the male to prostate cancer, though. Despite what many people may think, oh, if you have BPH, that is the precursor to prostate cancer, and that's not the case. The prostate gland can be palpated through a digital rectal examination, and the physician can determine the size of the lobes and if there's inflammation of the lobe, which could be an indicator, along with some blood tests such as PSA, prostate-specific antigen. It does lead to frequent infections, and continued obstruction can cause a distended bladder, dilated ureters, hydronephrosis, right, and eventually could lead to renal failure if not treated. So here's the urinary bladder. Here's the trigone where it all comes down. Here is the prostate gland, and then here is the prostatic urethra, and here is the obstruction. So let's look at the flow chart here of BPH. So there are some nodules. Remember, the nodules form due to hyperplasia, which results in hypertrophy, and that's in the inner prostate. When that increases in size, it will compress the urethra, which will then obstruct the flow of urine. So there'll be the difficulty initiating micturition. Micturition is the sophisticated term for urination, and it results in dribbling of urine rather than a steady, heavy stream, just a dribbling effect. So there will be incomplete emptying of the bladder, which then gives the male the feeling of urgency again and frequency to go. So it can also result, if there's the incomplete emptying and there's stagnation, then you get an infection, which could lead to cystitis. And that infection can ascend or work its way up the kidney, becoming a pyelonephritis, which can result in kidney damage. When the bladder gets distended, then you get this hydronephrosis, which can also result in kidney damage. So these are some of the complications of benign prostatic hypertrophy, right? You get the cystitis, you can get the pyelonephritis, and hydronephrosis, and permanent kidney damage. So the manifestations of BPH, there's the hesitancy in the starting of flow of urine. So it results in dribbling. There's increased frequency and urgency due to the incomplete bladder emptying that we saw here, the incomplete bladder emptying. There's increased peeing at night, right? Nocturia, increased peeing or frequency of urination at night. And dysuria occurs, painful urination, if an infection is present. The treatment, there's different medications There is a drug that's called dutasteride or Avodart that slows down the enlargement. There's Flomax that tries to increase the flow of the urine by relaxing the smooth muscle. And then they have some other drugs that are designed to decrease the progression of the hypertrophy, like Proscar and Cadura. You don't have to memorize these, but it's good to know because when you look at intake forms and it says current medications, they'll, patients will write these down. Prostate cancer now, this is the most common cancer in men greater than 50 years of age, and it's the third leading cause of cancer death in men. 1 in 6 men will be affected by this, and most of them are adenocarcinomas, meaning it's arising in the surface or near the surface of the actual gland. They are, the more undifferentiated the tumor, the more aggressive it will be. Many tumors are androgen dependent, like testosterone dependent. Both are invasive. They can be both invasive, but they can also spread. And I think I've shared with you in another lecture how one of my patients that did have prostate cancer was treated with seeds, but never went back for a follow-up, and it ended up metastasizing to his sacrum and lumbar spine. So some forms are highly aggressive and others are not. 5 to 10% are caused by an inherited mutation, but the other causes are high androgen levels, increased insulin-like growth factors, and the history of recurrent prostatitis. Not BPH, but prostatitis. The clinical manifestation of prostate cancer, there's a hard nodule that's felt on the periphery of the prostate gland. There's hesitancy in urination, decreased urine stream, frequent urination, and recurrent UTIs. Now, these 4 here sound very much like BPH. Okay. The diagnosis, the serum markers, besides the prostate exam, the digital exam, the serum blood markers are going to be the PSA, the prostate-specific antigen, and prostatic acid phosphatase. But PSA is the biggie. You want that somewhere between 0 and 4. But I've had some patients up at 14 or 15 on this, which were prostate cancer. You can also be diagnosed with ultrasound, biopsy, and bone scans would be needed to detect if it's spread or metastasized to the bones. Otherwise, surgery, there's the radical prostatectomy. There's radiation with external or implanted pellets. Those would be the seeds. Most patients refer to them as seeds. If it's androgen sensitive, then the orchiectomy is effective, as well as anti-testosterone drugs, such as giving them estrogen and estrogen creams and whatnot. There are new chemotherapies that are currently in trial. Now, testicular cancers, most of the testicular tumors are malignant. 1 in 300 men are affected, and it's the most common solid tumor cancer in young men. The primary age is between 15 to 35 years of age. I knew of a gentleman growing up who got this when he was 17 or 18. Was treated, had the testicle removed, and then about 20 years later came back and died shortly after. Pretty sad story. But these number of cases are increasing. And just like women do self-breast exam, it's important for men to do testicular self-exam, and that's important for early detection. The testicular cancer can originate from one type of cell or mixed cells from various sources. There is a type of tumor called a teratoma, where the tumor consists of a mixture of different germ cells. And there have been some of these tumors that actually have remnants of hair and remnants of teeth. Very, very bizarre type of tumor. Some malignant tumors secrete human chorionic gonadotrophin, HCG, which is the hormone that they look for to determine if a woman is pregnant, and alpha fetoprotein, AFP, which serves both as useful markers of diagnosis. Because of this, there have been, there are some men that say they thought they had testicular cancer. They bought a female pregnancy test. They urinated in it. It came back positive due to the presence of HCG. Now, that shouldn't be the diagnostic tool. It's, I would say, part of the earlier signs of part of the self-exam. If that did happen, then, go right to the physician for an official diagnosis. Testicular cancer, the spreading of it, the spreading pattern, it usually starts to spread to the lymph nodes in the pelvic region, where the iliac region is. There are these iliac lymph nodes. They are around the abdominal aorta in there, the para-aortic lymph nodes, but these are all considered pelvic lymph nodes. And then they start to ascend, and they move to the mediastinal. They move to the supraclavicular lymph nodes. And then through the blood, they start to spread to the lungs, the liver, the bone, and to the brain. Here is a malignant tumor of the testicle, right here. And this is the remnant of the spermatocord, what's left of the spermatocord after the dissection. The etiology, the hereditary factors, that there's a change in chromosome number 12, and a predisposing factor is what we talked about earlier, the cryptorchidism. Also, environmentally, exposure to herbicides, pesticides, any other environmental agent that may be a predisposing factor. Okay, because if there is a genetic component, this is what ends up pushing it over the edge. Testicular cancer, some of the manifestations, the tumors are hard, they're painless, they're usually unilateral. The testes may be enlarged or feel heavy. There's a dull achiness in the scrotum and in the pelvis region. And the hydrocele that we showed you earlier, or inflammation of the epididymis, that can also develop. And the male can develop female breast tissue, which is called gynecomastasia. That occurs if the tumor is hormone secreting, especially estrogen. The diagnosis for testicular cancer, the biopsy is not usually done, but they'll look for those tumor markers, the HCG and AFP. They'll do ultrasound, CT, and lymphangiography as well. In terms of treatment, the combination of surgery, remove the testes, oreectomy, radiation, and chemo. Now, if they're going to remove a testes, then usually men will donate their sperm. They'll freeze them, they'll preserve them for a later time if they're planning on having children in the future. Okay, and that brings an end to the male reproductive disorders. When we return, we will talk about the female reproductive disorders, and we'll start with uterine structural abnormalities and menstrual disorders.